It's a very important principle in improvement that you can't really improve without aim. And the aim doesn't come from improvement. It comes from you, what you care about, what you love, why you think you're on earth. It's the marriage of I'll even say noble aims, which is, to my case, try to reduce the suffering of the world.
Welcome to this episode of Walk and Talk Improvement. We're honored to welcome Don Berwick to this episode of Walk and Talk Improvement, where we're going to invite Don to explore key lessons for leadership in QI and share what motivates him to do his work with such passion and hope for the future.
Donald M. Berwick is one of the leading scholars, teachers and advocates in the world for continual improvement of healthcare systems.
He is a pediatrician, a long-standing member of the faculty of Harvard Medical School. He founded and led the Institute for Healthcare Improvement, a leading global non-profit organization in its field.
He was appointed by President Obama as administrator of the Centers for Medicare and Medicaid Services, where he served in 2010 and 2011.
He has counseled governments, clinical leaders and executives in dozens of nations across the world. He is an elected member of the National Academy of Medicine and the American Philosophical Society.
He has received numerous awards, including the Heinz Award for Public Policy, the Award of Honor of the American Hospitals Association, and the Gustav Leinhardt Award from the Institute of Medicine.
And Don Berwick is our guest on the Walk and Talk Improvement podcast today. I'm John Fizsimons, and I'm joined by my co-host, Juanita. Do you want to say hello there to everybody?
Hi, everyone. I'm Juanita, Guidera, and I'm a Programme Manager with the National Quality and Patient Safety in the Health Service Executive in Ireland. So, Don, you've been involved in quality and patient safety for several decades, and you're still passionate about making a difference, which says a lot about the type of person you are. So I'd like to start by exploring how intrinsic motivation and values have influenced you. And I'm curious to know, what was the catalyst for your interest in quality improvement? What inspired you? And more so, what has helped you sustain that interest?
Thank you for having me with you, John and Juanita. It's a total pleasure. I've had the honor to visit Ireland a few times, but not enough. And so I look forward to another chance. But chatting with you this way is just such a pleasure and an honor. It's actually a hard question to answer. My background traces to my childhood because my father was a doctor in a small town in the rural state of Connecticut where I grew up, a GP by your language. It was my only model of medicine, a man in a small town who kind of felt his duty was to help people all the time. Not perfect, but very dedicated. So this idea that I'm there for you and the flexibility in his practice, he took care of quite an impoverished rural population in our town and always did it without a grudge and motivated, I guess, by the work of being a healer. I once asked him why he liked being a doctor, and he said, I love solving puzzles. That was his answer. So I had this model, solo practice, single-handed practice. He had a fluoroscopy machine in his office. He went to the hospital every single day and rounded on his patients day and night. My bedroom as a child overlooked the driveway in our house, a gravel driveway. And many, many nights I would hear him start his car because I knew he was headed out to somebody's house who had chest pain. So I had this very clear and I guess nowadays romantic view of medicine. I never doubted I wanted to be a doctor from day one. The only thing I ever wanted to become was a doctor. And so I was lucky enough to do that. But then another part of my being got engaged because as I trained and started to take care of patients, things went wrong. They went wrong often. In those days, I blamed myself. Every error was my error. Every injury was one I caused. And I had no other framework than just personal responsibility. And then through really lucky happenstance, as a young physician still in training, I met a number of mentors who became my closest colleagues for life. Paul Batalden, for example, another pediatrician, Dave Gustafson, an engineer. We started talking with each other, and I suddenly realized that there was a different way to think about excellence, that excellence was not a property of effort. There's no try harder solution. I was already trying as hard as I possibly could. And still things went wrong. Tests got lost. In fact, in my life, I injured many patients. I can remember them. Never intentionally. I thought because of incompetence. Now I was beginning to learn a new theory, and I met W. Edwards Deming, the great teacher of quality of the last century, one of them. And I saw a science. I saw that there were ways to think about excellence that were different from the way I'd been taught, and that were much more interesting and actually kind of fun, the quality improvement world that I got introduced to, combined with my skills and desires as a clinician. And this group of people, this little group of people that were kind of on the same journey, we got to know each other well. And we decided to start an effort, first called the National Demonstration Project on Quality in Healthcare, and then eventually the Institute for Healthcare Improvement. And I was asked to become the first chief executive. I guess if there's a turning point, it's meeting the science. Later on, it changed because as I got into the other phases of my life, my wife had an extremely serious illness in the 1990s, almost died. And I watched day after day after day, things go wrong. It was terrifying. And so what was an intellectual hook became really, really personal.
Yeah, it's a really hard thing to be on the opposite side of the bed. Yeah, it's not easy.
Oh, man. Yeah. Oh, man. I mean, to feel so helpless in the face of things that were wrong. There's another side to it, which is the positive, which is as I got into this journey and met these colleagues who became lifelong colleagues, it was just such a joyous group. I mean, we really started to realize how much possibility there was in the enterprise of continuous learning and getting better. I'm a pediatrician. I'm father of 4, grandfather of 8. And I watched the joy in a healthy child as they learn, and that exactly the same joy is accessible through the approaches of improvement and stopping the blaming and the yelling and the table thumping and the targets. I mean, just so tempted to behave in a way that's nonsense, but it's so much more fun to learn.
John, can I just ask what you saw in Deming? Obviously early on, and I know we've all become so familiar with Deming now, and I think largely through you and your work, but what was a hook with Deming that you knew he was onto something different?
You have time for a little story,
Yeah, sure.
Along the way, as I began to say, wait a minute, the way I've been thinking about getting better, trying harder, pounding the table, yelling at people, incentive orientations, all of that was sterile and not working. And Paul Batalden, the friend that I mentioned, said, well, you ought to meet this guy, Deming. Little did I know that he was working hard with Deming, and in fact, knew him very well. W. Edwards Deming taught a 4-day course in a big hotel in Washington, D.C. Paul urged me to take the course. Probably the worst teaching environment I could imagine. This guy stood up on the stage and droned on for 4 days. But I decided to try it. So I went down. I was sitting in an audience of maybe 800 or 1,000 people, one of the very few medical people there. And he started teaching, and I started getting angry. I mean, I didn't understand what he was saying. What's this nonsense? What does this have to do with seeing patients? And I got very uncomfortable. And truth to tell, on day 2 of the 4-day course, I left. I walked right out, went to the airport, and flew back to Boston. Day 2, angry, wasting my time. And that night, as close as I've ever come to an epiphany, I was sleeping, and then I woke up suddenly, like in the middle of the night, and I was sweating. I was like agitated, and my wife woke up and said, what's going on with you? And then I just said, holy cow, he's right. I was being exposed to a disciplined, evidence-based, scientifically grounded theory about learning and getting better in complex systems that I had not met before. And it completely negated, actually, the approaches that I've been taking, which was all like report back the numbers and measure, and the other people are giving them rewards. Deming offered me a way to think. It was dramatically uncomfortable because changing one's mind is not easy. I went back to the airport. I flew back onto Washington, and I attended the last 2 days of the course. Wow, I was onto something here that was going to change my life. It's not religion. It sounds a little religious. It's just like, holy cow, there is a different way to think. That was Deming. I soon learned Deming was not by any means alone. He's one, but not the only scholar. He was one among a group of literally dozens of scholars and leaders and teachers and managers around the world, not in healthcare at the time, not in healthcare, except for Paul Batalden. Very few in healthcare who were learning a different way to think. And they were themselves grounded in the prior scientific work of people most people in medicine don't know about. Walter Schuhart, Russell Akoff. These were the scholars whose work was the foundation for learning. John Dewey, the famous educator, all of this comes together. Deming taught Joseph Juran was a extraordinarily bright guy, chess grandmaster, and wrote more books than I can count. Lived to 102, I think, or 101. He was very prolific and very, very helpful. Japanese scholars, the most important to me was a man named Noriaki Kano. I had the chance to meet Kano several times. Man, he had ways to think that were new, and all that novelty was so refreshing. And then I met Bland Godfrey. Bland was the head of quality at Bell Laboratories, which many people in the field would regard as the kind of originator laboratory for improvement theory. Walter Schuhart was in the Bell Western Electric Labs before it became Bell Labs. And Bland and I immediately bonded and we started this demonstration project. All important, but really, it's still a problem. In order to understand what I now regard as mature approaches to learning and change, really, it's not just learning. You have to give up a set of assumptions that are quite widespread, almost hegemonic in the world of leadership.
Yeah. And so many of these things come from outside of healthcare. We're trying to bring in that approach and that way of thinking and learning.
Indeed. One of the things you let go of is that we're so different. We are different, of course. It's a noble and exciting field to be taking care of patients, but we still deal with processes. We still have interdependency. We still try to use data properly. We still have to learn our way to improvement. There's a lot of overlap. Nowadays, 40 years later, I took Deming's course in 1986, so it shows you how old I am. Nowadays, there's plenty of real deep scholarship in healthcare, so you actually can learn a lot from our professional colleagues.
Yeah. I'm struck by the breadth of, people that have influenced you. You obviously had a core set of values that you brought to your work. I wonder about the polarization within society at the moment, the diversity within our work environments and the challenges that brings. Is it necessary to have a set of common values to make change happen?
Maybe not. The mechanics of change are probably similar, whether you want to save lives in sub-Saharan Africa or rob banks. It's all about processes and data and who depends on whom and how you work that through. I see the quality methods largely as useful in any improvement endeavor. If you want to improve your marriage, you can use them. But it's not the point. The point is that we have a mission. And the mission is what motivates us. It's not the tools and methods. They're exciting and they're interesting, but the only source of energy for change that I know in most healthy people is growth, development, learning, and helping others. It sounds so naive nowadays since there is so much ugliness in the world. But underneath it all, I really do have enormous faith in people in general. I think we want to help each other, and the quality improvement methods are a way to get that done. But it's a very important principle in improvement that you can't really improve without aim. And aim doesn't come from improvement. It comes from you, what you care about, what you love, why you think you're on earth. It's the marriage of I'll even say noble aims, which is, to my case, try to reduce the suffering of the world. Try to reduce the suffering of the world and then do it in a smart way, a smart and inclusive and respectful and joyous way. I'm probably going to get this wrong, but there's a quote from Saint-Exupéry, the author of Little Prince. He says, to become a man, but it's gendered. It means to become an adult, means to take responsibility for the solution of problems you did not cause.
Mm-hmm.
I feel that so deeply. I didn't cause the inequities in the world and the poverty in the global South, but I sure feel like I got to do something about it.
Yeah.
And I've always been struck by that, Don, and in your writing as well, the moral sense. You have a lovely quote, I have it on a slide somewhere, that says, quality is goodness.
Yeah.
It's the simplicity of that and the clarity of that. And I think in terms of engaging people, that's very powerful.
Yeah. I spend many Talmudic sessions with people who try to define quality. It's not hard.
Yeah.
It just means meeting need.
Yeah.
You decide what needs you want to meet. And then you say, well, in that endeavor, like you said, John, what is goodness? What are the dimensions of excellence? I have a story. A friend of mine, unfortunately, got a diagnosis of very late stage cancer last week, and he had to have a biopsy. And I said, how'd it go? And he said, well, I asked when the result will be back. And he said, the answer they gave me was in 5 business days. And my friend said, what is that about? That happened to be on a Saturday. He said, I'm sick and tired and suffering and in pain and scared, and it's Saturday. What is 5 business days? How did that get into the vocabulary? Now, of course, we know the backstory probably. It may be very hard to get pathologists to read slides on Sunday. I don't know, but I know what goodness is, which is help the guy, relieve his pain, relieve his uncertainty now, not later, now. When we slip away from that as the compass, it's not right.
Yeah. I can even see it in my own journey. I would say, at the beginning, I suppose I was much more interested in the improvement side of things. We're going to get on and there's action to be taken. But I think as time has gone on, I come back to look at the importance of understanding quality in itself. and even to the simple task of what are we trying to achieve here, that it is goodness. And that's been very valuable. And I think you've worked across 5 decades now. And have you seen this term or this understanding of what we mean by quality change over that time?
Yes. I think first we asked the question. I mean, when I was in training, I think we took excellence for granted in a way. The message to me as a young physician in training was try hard, do well, it's your patient. So one is like effort. You really have to be committed. I think another was that I was in Harvard teaching hospitals. They knew they were the best. And there wasn't this deep inquiry of how are we doing as an institution. It was, we're Harvard. What are you talking about? Of course, we're great. There certainly wasn't teaching on what we today would call maybe person-centeredness or patient-centeredness. I wasn't trained to ask a patient how I was doing. My better mentors did that, but it wasn't the job. So in a way, the questions weren't asked, I guess. And when things went wrong, it was more like, well, stuff happens, and that's the way it is. It's a bad disease. Nobody's perfect. A lot of what Joseph Duran used to call disconnecting the alarms. The alarms were disconnected. Then it changed. So if you look back at the history, I guess starting in the late 1980s, like 1990s, 2000s, there was research. Jack Winberg from Dartmouth was key, showing the phenomenally large levels of variation of what we did. It was like spinning a roulette wheel. What happened to you depended on where the little ball ended in terms of what doctor you saw. Tremendous variation, order of magnitude variation. We had work by Beth McGlynn and others showing gaps between what we knew to do and what actually happened. Beth's famous paper, I think it was in the Annals of Internal Medicine, was it 50% of what should have happened didn't.
Yeah. I think in the New England Journal as well, didn't she? And that's been replicated around the world, hasn't it? I think it's not just the US.
Oh, yeah. It was leading work in Australia. It was in England, just a lot of validation. So eyes really did get opened. And I think for us in the US, it was the National Academy of Medicine reports in 1999 and 2001 to Err is Human, which was a report on safety hazards. And then 2001 was Crossing the Quality Chasm, which laid out dimensions of defect, none of which traced to bad intention or laziness or dishonesty on the part of the professionals. Professionals were trying hard. Everyone was trying hard. I think everyone, most of the time, is trying pretty hard. This was the importation of the perceptions of Duran and Deming and others about systems thinking, and those in healthcare who had been doing that, which, for example, there was already a tremendous reservoir of knowledge in the specialty of anesthesiology decades before other specialties became aware of the systems approach to improvement. Anesthesiology was there, and they had the results to show it. I mean, they had made surgery so much safer. But I would say 2000, 2010, that was a period of coming aware of a different way to think about quality, much as I met when I heard Deming. What didn't change enough is leadership. If we're going to deliver healthcare in organizations and governments and complex systems of interpersonal systems, leaders matter a ton. And I still, even to this day, we're speaking in 2025, a deep understanding of improvement approaches, a rejection of outmoded and unscientific approaches to improvement has not penetrated at the level of leadership that I wish it would. By leaders here, I mean both executives, both clinical and non-clinical executives, but also boards of directors and trustees and ministries of health. We've got a gap. The methods that work haven't been universally embraced. The second thing is short-sightedness, driven by, in the U.S., I don't know the scene in Ireland, but extensive, almost overwhelming financialization of healthcare, where rather suddenly the first topic was money, always money, money, money. Boards of trustees in the U.S. consist largely of financiers and investors and real estate moguls, not clinicians. They're caring people. They care about patients, but they put the money in the foreground and the patient a little bit in the background. No, not a little bit, sometimes a lot. Like that thing to my friend, 5 business days. Who's responsible for that?
Yeah.
For A, is it a problem? It's definitely a problem from the viewpoint of quality. And where does the buck stop? Who's supposed to detect that and work out a different culture? Well, that is a culture being driven by money. We saw it in England in the National Health Service as a kind of market approach, entered a system which is not benefiting, didn't benefit and won't benefit from market thinking. And I see it all over the world. In the view of the founders of the field, Deming, Duran, and others, there's a very serious business belief, which is if you meet needs, you will thrive financially. I don't know if that's true in healthcare. In healthcare in the U.S., it's not true right now. But in many environments, certainly the single-payer environments in the UK nations, I think it's probably true. If you actually focus on goodness, to use your term, John, you will do better financially, much better, tons better.
Yeah.
But that's not believed. That's not believed.
And I think underpinning so much of that is this idea of the culture that surrounds quality. And in particular, I think that's what Edgar Schein used to say, the only job that leaders have is to shape and manage culture. And how do we do that?
Yeah.
We've slightly different, maybe financial levers here, but we still have them. Finance and being able to pay for things or access is still a huge challenge.
It's sometimes when I get on this topic, I sound and maybe even feel disrespectful of leaders. Leaders are trying hard, just like the rest of us. They're in tough jobs and they've got to balance a lot of stuff. So I don't mean to talk down the leaders or to be demeaning, but I do feel that there are a certain set of beliefs that have made it into maybe in our leadership education systems, maybe into culture, that are wrong. For example, do you believe that most people are trying hard most of the time, or must you make them try hard? If you don't believe they're trying hard most of the time to have pride in their work, you're done. You can't be an improvement leader. You have to trust something about the intrinsic motivation of people. Not everybody. There are thieves. There are jerks. There are people that are in the wrong job. But overall, it's this deep, deep trust in the workforce. Why? Partly because you're going to use their knowledge as one of the greatest resources you have. They're the improver army that you need as long as you allow them, liberate them to actually learn and contribute and help each other and help you. So there's a belief system about workers. Part of that is the role of incentive. Most of my colleagues in management, even those in quality improvement, think I'm totally wrong, but I do believe that incentive-based leadership is deeply impoverished. There's a deep misunderstanding with the workforce. Yes, we need to celebrate and pay fairly and create conditions of work that are doable. But if you believe that extra pound sterling, whatever it is going to produce the excellence you need, you're just wrong. They're already trying. What are you thinking? You misunderstand if you think that this extrinsic stuff you can produce is going to produce excellence. It'll produce mediocrity. Maybe a tiny, but some improvement. But giving up the incentive-based approach to leadership is I think, wrong.
It nearly puts a ceiling in place in terms of what you're going to aspire to as well, if that's all you ever have to achieve.
Yeah, the theory teaches us if you want to do better, you have to redesign the system. You need a different way to do things. How are you going to do that? We're going to find a lot of ideas about how to do things differently and then recruit the wisdom of the workforce to help instantiate the better new way. How are you going to do that? By learning. Same way my grandchildren ride a bicycle. They fall off the bike. They get on the bike, they try something you've never done before, and they fall and they cry, and then they get back on the bike. You can't learn without that kind of attitude of try and learn. Well, if you're in an environment of fear or contingency, where every failure reduces your income or reputation, you're not going to get improvement. You're not going to get learning. Learning involves taking risks and celebrating what we learn, even when we fail. It's all set up wrong now. And then the holy dollar, this belief that it's all about the money. My leadership is for the money. You do the right thing for the people you're trying to help, and the money will sooner or later follow. The other thing is attitude toward waste. One of the paradoxes of leadership, to me, is meeting in the C-suites, figuring out how to reduce costs and how to, not go over budget or whatever. And the money's there. It's right in front of them. It's in the waste that is intercalated throughout the very system they're responsible for. Waste of energy, waste of ideas, waste of resources, waste of material.
Yeah.
The workforce live in that waste. They see it all the time. Why are you wasting my time, says the nurse. Filling out forms that nobody's ever going to read. Rules that are just dumb. They make no sense. They did make sense sometime, but not now. Well, it's the leader's job to support the rooting out of that waste and return that money to better uses. Nope. They're not doing that. What they're trying to do is find more revenue, argue with the government to increase the payment or salaries. So there's very little sensitivity to waste. And the pursuit of waste is absolutely at the core of a lot of improvement.
Yeah. One of the things that we talked about is that whole role of coaches or leaders that have coaching skills. And if you were thinking about that, and thinking in particular of waste or thinking of that broader quality improvement agenda, how important do you think those coaching skills are for leaders? And what sort of advice would you give people that want to develop those skills?
Well, they're essential. Coach is one of the best metaphors for leadership in the modern era. So what does a great coach do? My grandson, 15 years old, is a middle distance runner. He runs the mile and 2-mile race in his high school. He's done very, very well. He's already a state-level athlete at age 15. He talks about it, and I've watched his coach. His coach is a woman, also a very accomplished runner. Her approach to him is so instructive, which is, number one, is a lot of positive, thank you, great, look at what you just did. I noticed that. So it's this nurturing of self-esteem, not a hint of fear, no fear, no fear. And then lots of technical advice, which is not pushed on my grandson, but was pulled by him. 2 weeks ago, he went to England with his family and knew he would be on airplanes in a hotel. And he asked his coach, what do I do during that period when I'm not in a familiar exercise environment? And they worked out a schedule and a way for him to actually handle that. Teamwork, you wouldn't think that running the mile is a team event, but it is for her. There's a chance for these people to help each other as they run, pacing each other, advising each other, celebrating each other. So this all about welcoming new ideas, trying new things, celebrating success, learning from failures. Why do we fall short of our target? Let's think about that. That's what leadership is. And encouraging high levels of cooperation. One of the problems with the incentive structures that leaders seem hooked on is it discourages cooperation because it's a win-lose situation. You're graded on a curve, and when somebody gets a lot, you get less. It's not going to produce better surgery. How could it?
Yeah. It's one of the things and one of the biggest challenges that we hear coming back time and time again is we don't have the time. I think in high pressure environments, sometimes the quality improvement work is seen as a nice to have. It's not necessarily worthy of your attention because it's not where you're going to get measured. And in addition to that, we have the politics and the power and organizational dynamics that can impact how we work. So you've worked as a clinician and you've established organizations and you've counseled governments. What were the biggest challenges you faced in advocating for quality improvement, and how did you overcome them?
I'm not sure I did, Juanita, just what you said. It's called understandable impatience. I remember meeting with a minister of health, I won't name the country, but there had been a remarkable success in the country on waiting times. There was a real problem with delays in access to GPs. And wisely, the ministry had supported a set of sort of local experiments where people worked on scheduling systems and queuing theory and other scientifically grounded stuff. And it had absolutely beaten the problem. They had documented remarkable improvements in access, by the way, with no changes in resources. And the minister of health I was meeting with was made aware of that. I think he little pounded the table. He said, okay, we'll do it everywhere now. Same change. Yeah, I mean, the sciences are pretty well developed. But on the other hand, if you look back, that process was probably an 18-month process of buy-in, learning locally how to adopt this new scheduling approach, how to change roles so that there'd be more continuous flow. That would be like watching a kid who wants to learn to ride a bike. You're coaching him and you see another kid who's riding the bike beautifully and you say, do that.
Yeah.
Do that. It would be pretty dumb. Your student, your mentee would cry. They wouldn't try. They would know that it isn't going to work. And so they'll get angry or do something unproductive.
Crying at that say.
And then there's change of leadership because every time the government turns over, you get a new minister. He or she wants to put their stamp on things. So continuity is at risk. There are other big barriers, but it can amount to not having the patience and the willingness to invest in learning. When you're hemorrhaging money and not meeting budget, it gets worse because people say, oh, I need it now. I'm sorry, I need it now. I wish I could make it now. I can't do it now. I can do it later. Give me some headroom and we'll get this done.
Yeah. Do you think it's possible to justify, I had this conversation with somebody last week where they said, if you've got 5 patients in front of you and you've another 10 in the waiting room, you've more coming and the waiting list is long, can you justify spending the time on improvement when the patient, the immediate need is in front of you?
A couple of answers. One is, what's your alternative? You can keep doing what you've always done and you'll get the same result. So if you don't invest now, what would possibly make you think that it's going to somehow get better? You could pound the table and hand out rewards and punishments, but I just said that's not going to get you very far. It'll get you into combat. Be an adult here. I'm wide open for business. If you have a different idea, bring it on and let's see if that works. We're not talking about a ton of extra time. We're just talking about a bit. So one good thing to do if you're a leader who thinks you don't have the time in your system to invest in learning, stop some waste. Say, we're going to stop the following 8 meetings a week because they don't do anything for anybody. We're going to use that time now for learning. I think that actually a very smart move is to begin your improvement journey with waste reduction and reinvestment of time.
Yeah.
My colleague Juanita calls that ex-novation. That also requires listening to the workforce because I'm sorry, CEO, I'm sorry, CMO, CNO, you don't know where the waste is. They do. And so your time has to be spent listening to and mobilizing that knowledge and giving them the authority to stop doing stupid things.
Yeah, I love that.
Don, one of the things I've always admired about you is your ability to communicate. And I know you have a podcast now that you do with Guidera, and we've listened to some of those, and they're fantastic. Don't get too meta,
Yeah.
but that's a new way of communicating. I know writing for you has been a very important way of communicating. And I also imagine it's helped you maybe to get your own thoughts straight and speaking and presenting. What have you learned from those things? How do we communicate to everybody to get everybody on board?
Well, you're so right, John. I think our podcast is called Turn on the Lights. Turn on the Lights. I encourage people to listen to it. Its objective is to try to reach a general public with ways to understand that what's going on in healthcare, good news, bad news, complex things that highly skilled professionals in the public don't understand. So yeah, more outreach to the public is of great interest to me. Your comments are very kind, but I don't feel that successful. Basically, in the quality movement, we're still pretty much talking to ourselves in a bubble. And it's very hard to get out of that bubble and reach audiences that are unfamiliar, as I was when I first met Denny. I'm not very good at it, and I want to learn more. One of the routes there is going to have to be mature, open-minded, respectful conversation with the general public that can have relief. But I need a way to communicate that more broadly, and I'm really searching for that. I'd love to find a way to do what you're doing, Juanita and John, to try to reach a general public. Isn't that what a good doctor does? You begin by listening, and I think maybe that's the way to do it. But I don't have a magic answer right now. I am putting my own time into it, and I hope to find a way to be a better communicator to the people who really need relief.
One of the ways, and I think this again has I think come forward in maybe the last 5 or 10 years, is this idea of co-production.
Yes.
That whatever we do, we have to do it together, and we have to embrace all of the perspectives, and that might be slow, it might be frustrating, but if we don't do it that way, we're not going to get something that is meaningful and sustainable.
I think you're onto something there, John. And co-production has a limited view, which is if I see a patient, I'm trying to help health grow, I can't deliver that to the patient. We can do it together, but it's only going to be done by a deep understanding and listening to what matters to the person that I'm trying to help. So that's the individualized approach. We've lost track as a community in our country of a government founded on and acting with decency, inevitably decency, with a sense of mutuality and responsibility for each other. And that decent civilization, I think, obviously has to be co-produced. We have to decide on our values and do it together, and we've lost that tail. I'll take your point home, John. It's really very meaningful, I think.
It's a global point. So many of the problems I see here, the solutions are in our communities and way before we get to the GP clinic or our hospital.
Yeah, I think that's a learning for me. I've worked at the national level in this country and elsewhere, and I've been in the halls of power, I guess. And there's a seductive side to that where, if we do the right thing in Whitehall or capital city, then that'll trickle down and everything will be better. Yeah, I mean, there have to be circumstances set, but I guess over time, I'm more and more hoping that I can place my hope in localities and municipalities, local settings. That was done very well in your Celtic colleagues in Scotland. At the height of their work on improvement, which was really quite pace-setting for the world, they did a lot of it at the municipal level. Same in Sweden, which is very worth studying, is municipalities and counties where the real action went. The idea that the smart national government figures out what everyone should do wasn't as strong as the idea that a smart national government and supports localities to do what they know they need to do with the tools and methods and science.
Yeah.
We've been looking at the whole area of patient partnership in recent years and co-production, and how do you involve patients and how do you involve them in the whole reform process, but also, policies within local hospitals, community settings and so on. One of the things that consistently comes up is the whole imbalance of power, so that the health service, they book the meeting room, they pay for the travel and subsistence. Ultimately, at the end of it, no matter what you do, even if you're asking for someone's opinion, there's still an imbalance there. Is it something you've come across, and have you any suggestions for how you can bypass it so that we have that equal voice at the table and that sense that actually we can say what we need to say?
First, I think that the sincere leaders that want to listen are finding ways to do that. I don't think they're just ticking a box. They actually want to know. And I see that happening. I work a lot with whales, and there's consultations going on in Wales that I think are pretty authentic. Certainly in Sweden, awful lot of involvement of communities and just people in shaping their care. So it certainly can be done. If as a senior person in government or organization, you think it's a ticking the box issue, we had a focus group. I've met with 3 patients. You haven't got it. I mean, that's not what we're talking about ultimately. A change in the balance of power. What is kind of interesting to me, and often the people who we're saying are so powerful, they don't feel it. I mean, they're sitting in their offices saying, I say go and nobody goes. I say, jump and nobody jumps. Some of the dysfunctional behaviors that we see emerge from ministries of health and executive suites is precisely because they're feeling so helpless. The workforce says you have all the power, and they say, it doesn't feel that way to me. Please trust that people want to help. Go into the room with 2 ideas. One is people really want to help, and you don't have all the answers. Any good leader actually does know that. Acting that way, that redresses some of the power balance. We're not, by the way, talking about racism, vicious economic inequity. That's a problem that lies outside the quality realm. That's a political choice that countries make, which is, are we going to allow asymmetries of wealth and income and consequences of racism and ethnic fears going to dominate our country? That's a different question. And the answer is, you better not, but there's a lot of it.
And Don, you did a wonderful podcast recently with the folks from Nuka in Alaska.
Yeah.
That's an amazing story, isn't it? Of power being truly and true co-production.
One of the best in the world.
Yeah.
I urge people to listen to that. In the Nuka situation in Alaska, it actually was shaped by law, which is that a law came into being which handed over the control of the native health system, which was previously to that simply a federal government agency. But it said, no, the tribes own their care. So you now work for the tribe, for the people, for the indigenous nation. And it's true. They've made it happen. And the Nuka system is designed around that. So we have, very accomplished professionals, specialists, primary care doctors, nurses, pharmacists, deferring, inquiring, listening to, and they don't call their patients, by the way. I don't know if you caught it, they call them customer owners. That's a mouthful.
Yes. Yeah.
But customer owner, what does that mean?
Yeah, it's fascinating.
Yeah. And it hasn't done with conflict and demoralization. It's done with a sense of service.
Yeah. This is the wonderful thing I've appreciated, and I think, again, through the work of IHI and the partnership with BMJ, that from around the world, like you talked about Sweden or Wales or Alaska, the US, that we can learn from each other, and there's so much that we can learn. And even just that possibility that we can do things so differently, like that model in Alaska.
I mean, there's a quote by Merlin in The Sword and the Stone that I can never get right. I got to memorize it, but it's like Merlin says, I get depressed, I have a cure. I go and try to learn something. And I think he's right. Merlin's right.
I'm conscious of our time and of your time, and I'm so grateful. We might start to kind of think about that. And I think from that quote from Merlin there, in terms of the most important things you have learned, Deming possibly borrowed it from Napoleon, but constancy of purpose. You certainly have had a constancy of purpose, I think, throughout your life's work. But what have you learned about trying to keep that energized and keep going?
You can't do it alone, is what I've learned. A single hero, or even with the most dedication in the world, you're going to fail. No one's got that much energy. So for me, the constant rescue is friends and supporters. Family, of course. Family is crucial.
Yes.
Mapping family back into this picture for me has been life's blood. But also there are people all over the world that are just like you. You're not a bit more noble or more wise. You don't know more than them, but you know stuff, they know stuff. And if you can get together, have a platform, some kind of way to pick something you'd like to do together and do it together, that's the whole secret. Loneliness isn't a good place to be. I've been very blessed. I mean, ICHI is a community of tens of thousands, maybe hundreds of thousands of people around the world. I have this wonderful experience. I can fly to Singapore or Dublin or Paris or Kyoto. And as I step off the plane, there'll be people there who want to do what I want to do. And that's what a privilege that is. What a privilege.
Yeah. Yeah. And I think the thinking and the language allows us into this community where we can come together to solve these common problems.
Uniting instead of dividing.
When we think about this work, And for all those people that are planning at the moment and thinking about climate and politics and AI and all of those, joyful topics and the challenges that are there, what advice would you give them for future-proofing the system?
We have to play with the young now. This pipeline of wonderful young people who want to make a difference. They need mentors and people to encourage them. And, I want to be one of them. What else do we have? The young.
Yeah.
The only thing about the future is we don't know what it is. So who knows what the next big, it's obviously AI right now, but circumstances are going to change. We better be agile. There's no fixed solutions here. Jim Reason, the great scholar of patient safety who died just recently, Jim used to say safety, one of the dimensions of goodness, John, is a continually emerging property of a dynamic system. You can't make something safe and walk away. It never, ever, ever, ever happens. It's a continually emerging property. So is the pursuit of improvement. And that's building in that dynamic, that awareness of the dynamics of goodness, I think is probably pretty important.
That is. And if I was to say to you, what message would you like to leave our audience with? What is it, the lasting message that you'd like to leave them with today?
Find each other. Don't be alone. Adhere to your purpose in life, the good that you want to do, and do it together. Use the compass and be together. That's worked for me, I guess, as well as anything has.
I love that.
If you get despairing, either talk to a child or talk to a patient, because they will get you out of your funk.
Very quickly. Very, very, very quickly. I have one final question. I'll pass over to you then, John. And it's, did you ever tell Deming that you hopped on a plane and went home and then came back?
I never had a chance to. I wish I had. My career and his overlapped briefly, but I didn't actually ever had the sit down I'd love to have had with him to say, first, thank you. I did with Duran. I mean, Joe Duran was a great mentor. But Deming, no. I've had many imaginary conversations. But, he had many students, many protégés. One of them, by far my most important mentor in my entire life, was Tom Nolan, who died quite tragically just a few years ago at much too young an age. But meeting with Tom and spending a dinner with Tom was like eating Godiva chocolates. What a guy.
I had the pleasure to meet him once, Don, at the forum in Florida. Yeah, very, very wonderful man.
Maintained optimism and always was curious. What do we need to learn here? And amazing man. Yeah.
Yeah. There's a few people in my life that I've met that just the sort of person you can pick up the phone and have a conversation with, and they just set you right. And they ground you, I think, when it gets hard, and they just inspire you. That resonates. John, anything else that you wanted to ask?
I think we've really asked Don all the hard questions. And thank you so much, Don, for your time and your kindness and your wisdom. And it's been a real pleasure having you here with us on the Walk and Talk Improvement podcast. Thank you.
Thank you so much. Thank you.
Pleasure's mine. Thank you so much for having me.
As we come to the end of this Walk and Talk Improvement podcast, we would like to thank Don Berwick for sharing his wisdom and experience so willingly. It's been such a privilege. For you as a listener, we hope Don's insights will continue to inspire you in your work to improve health and social care services. We hope you enjoyed this episode of Walk and Talk Improvement, and if you would like to hear more content like this, you can find us wherever you get your podcasts. Thank you for listening.